Good morning, everyone. The topic of my presentation today is role of endoscopic ultrasound in portal hypertension. And the outline of my talks are something about basics of the EUS, the role of EUS in esophageal varices, then gastric varices, where the EUS holds a lot of potential, role of EUS in liver biopsy, portal pressure measurement, and elastography. I've made my presentation in such a way that it should be beneficial to the residents especially. Now coming to the basics of the radial EUS, basically there are two types of EUS scopes, the radial one and the linear one. In the radial, the field of vision is 360 degree and it is perpendicular to the shaft of the scope, as we can see here. But it has got only diagnostic potential. But it is quite easy to learn, as the images are quite similar to that of a CT scan. The linear EUS scopes are the workhorse of most of the endosonographers because they have got both the diagnostic as well as therapeutic potential. And the field of vision is parallel to the shaft of the scope. Now coming to the esophageal varices, the varices that we see in routine upper GI endoscopy are just the tip of the iceberg because we can see only the lumen of the esophagus and the varices here. But we do not know what is happening outside the esophagus and how have they formed and why have they formed. Actually, there are two types of peri-esophageal collateral vessels. The smaller ones which are adjacent to the wall of the esophagus and the larger one which are a bit away from the wall of the esophagus, and both of these are connected to the varices with the help of the perforator veins. And these vessels can be seen quite easily with the help of radial EUS scopes or the ultrasound mini probes. As we can see here, these are the small peri-esophageal vessels outside the wall of the esophagus, adjacent to it. These are the bigger ones. These are the para-esophageal vessels which are away from the wall of the esophagus. And these are the varices in the esophagus lumen. And they are connected with the peri-vessels with the help of the perforator vessels. A bigger view. These are the varices in the esophagus which can be easily seen with the help of the Doppler mode of the EUS. And these are connected through the perforator veins to the peri-esophageal collateral vessels. Now, how does this knowledge help us in the management of patients of esophageal varices? There have been various studies which have analyzed the predictors of the esophageal varices recurrence after endotherapy. The most important feeder vessel for the esophageal varices is the left gastric vein, which rises from the portal vein. And the varices also get a small contribution from the short gastric vein as well. And this left gastric vein divides into anterior branch and the posterior branch. Studies have shown that more is the diameter of this left gastric vein or the high the hepatofugal flow velocity in this vessel, the chances of recurrences of the varices are more. Also, if the varices are fed by the anterior branch, the chances of recurrence of the varices is more. Now coming to the peri and the para vessels, studies have shown if the diameter of the para and the peri-esophageal collateral vessels is more, or the number is more, then there is high chances of recurrence of these esophageal varices. Also, studies have shown that if the perforator veins are more in diameter, then they will lead to more chances of recurrence of the esophageal varices after endotherapy. Coming to the esophageal varices, we can objectively measure the size of the varices with the help of EUS, and also we can see various red color signs on the EUS. For example, the hematocystic spots will appear as the secular aneurysm on the wall of the esophagus. There is one randomized control trial in which EUS guided EST was compared with conventional UGI with EST, published in 2006 GI endoscopy, in which unfortunately the EUS guided therapy was not found to be better than the conventional endotherapy. Now coming to gastric varices, where EUS holds a lot of potential. Everyone knows the Sudden Search classification, which is followed worldwide. Most of the studies have focused on the GOV2 and IgV1 because they are more difficult to be treated endoscopically. Now, as far as the detection of the gastric varices is concerned, EUS is better definitely compared to upper GI endoscopy, and in this study, considering EUS as the gold standard, nearly 50% of the patients were missed by doing conventional upper GI endoscopy because most of the varices, the gastric varices, are having a predominant submucosal component. And also they can be hidden beneath the gastric folds, making it difficult to visualize on conventional upper GI endoscopy. The acute gastric varices bleed can be a nightmare even for an expert endoscopist, because the blood will keep on accumulating here in the fundus, and also presence of food residues will make it difficult to visualize. Also, we cannot see the perforator vessels, and after doing endotherapy, we cannot assess scientifically whether the varices have been obliterated or not. We just need to rely on the catheters and then keep on probing whether the varice is hardened or it is still soft. So it's not a scientific way of doing endotherapy and assessing the success of the endotherapy. And with the help of EUS, we can tackle all these 4 factors quite easily. Now coming to the role of EUS in the management of these patients. This was an old study, which was actually a EUS assisted endotherapy was done, where after 2 weeks of the upper GI endoscopy with glue injection, EUS was done to see any residual flow in the varices. And if the flow was there, then again upper GI endoscopy was done. And it was compared to the historical control, and in this it was found that EUS assisted endotherapy led to less recurrence of the bleeding compared to the conventional method of treatment of these patients. So as far as gastric varices are concerned, the upper GI endoscopy with glue therapy, cyanoacrylate glue, either octyl or butyl, still is considered the standard of endotherapy care, and it is successful in nearly 90 to 95% of the patients. However, the issue is of rebleed, which is seen in nearly 15 to 30% of the patients, and also it is not free from the side effects. The most dreaded complication is the pulmonary embolism, or if a patent foramen ovale is there or ASD is there, then it can lead to systemic embolism. And also deaths have been reported despite doing successful endotherapy. So this was the first case series of 5 patients, of pilot study of 5 patients, where EUS guided injection of glue was done into the perforator feeding vessels in patients of gastric varices. And actually we can very easily see the gastric varices by doing EUS. We can target them with the help of FNA needle, and then subsequently we can inject glue in them. And also if the glue is mixed with lipiodal, then we can see under fluoroscopy guidance as well. But it was acknowledged even by those expert endoscopists that it was quite difficult to actually see the afferent and the efferent vessels, because if inadvertently there is injection of the glue into the efferent vessels, it can also lead to systemic embolism. 10 months of follow-up in this study, and no recurrence of bleed was seen in these 5 patients. Subsequently, there was a prospective study of 40 patients of acute gastric variceal bleed, in which bleeding was immediately stopped in 100% of these patients. However, in long term, 15% of these patients did require other sort of endotherapy in the form of rescue tips or liver transplantation. So EUS guided glue injection is having the same complications, risk of complications of glue embolism, and also the recurrent of bleeding. And there have been several case reports where EUS guided endotherapy was done, and it led to embolism in the systemic circulation or in the pulmonary circulation. As example, we can see here the glue is injected in the efferent vessels, and it is migrating through the gastrorenal shunt into the pulmonary circulation, which can be very easily seen under fluoroscopy guidance. In these are the foreign bodies present in the lungs, on the X-ray and CT scan. So another modality of treatment is the coil injection. These coils are the metal coils with synthetic fibers over them, and if injected in multiple numbers, then it will form a mesh-like substance which will hamper the flow of the blood. And they come in various lengths, and they come preloaded in a sheath in certain configuration. And when they are placed in the EUS FNA needle and then pushed from behind by the stylet, then they are released in the varices, and then they acquire the spiral-shaped configuration. They come in various lengths, and depending upon the size of the varix to be treated, the length of the diameter of the coil should be chosen. They come from the 3 millimeter to 20 millimeter in diameter, and it is very important that the diameter of the varix of the coil chosen should be at least 20 to 25% more than the diameter of the varix which is chosen. Example, we can see here, this is a small varix which is chosen to be coil embolization. And if the coil is small in size, then even these coils can migrate into the systemic or pulmonary circulation. So this was a retrospective study comparing EUS guided coil versus EUS guided glue therapy for patients of gastric varices. And in this The success rate was same from both the modalities. However, the rate of complication was less with the US guided coil injection. So US guided coil and glue have got both complications in the form that if we do US guided glue, then the risk of embolism is still there. If we have to inject coils, then they are to be multiple in number so as to form a mesh, and it increases the cost of the procedure. So a novel method was devised by Dr. Kenneth Binmoller, where if we inject coil first and subsequently followed by the glue therapy, then the coil will actually act as a scaffold and will tend to retain the glue, and thereby it will reduce the amount of glue required, and also the number of coils required will be less. So this was an ex vivo experiment where in a hypernized blood, coil was placed followed by injection of the glue, and the glue immediately got adhered to the coil so much that both the coil and glue could be removed in one piece, and there was no residual glue left behind in the container. This is a video which has been given to me by Dr. Vikram sir, where he is doing endotherapy of the patients who had bled recently, found to be having gastric varices. It is always important to do a routine upper GI endoscopy before contemplating glue therapy with EUS to see if there are any esophageal varices present or not, to characterize the gastric varices, and also to see if there is any concomitant other pathology. We insufflate the stomach lumen with water to better delineate the gastric varices and differentiate them from the para and perigastric collaterals. Subsequently, with the help of 19-gauge needle, the varice is punctured. We have to be assured that we are in the lumen of the varix. We can aspirate the blood to confirm that. And after that, coil is injected. Depending upon the size of the varix chosen, the coil should be selected carefully. And after coil, glue is injected. And if any residual varix is left, then again we can inject glue or other coil. And then we can objectively assess the success of the endotherapy with the help of the Doppler mode. As we can see here, the glue has completely opacified the varix. And there is, sometimes we can also see the glue cast with shadowing to confirm that the varix has been completely obliterated. So this is the largest study published as of now of 152 patients. It is a retrospective study seeing the result of US guided coil and glue, where 7 patients were having active bleeding, 105 patients had a history of bleed, and 40 patients had come for primary prophylaxis of the gastric varices. Majority of these patients was IgV1, and the mean diameter of the varix was 2.1 centimeter. The number of coils required was just 1.4, and the amount of glue required was only 2 ml. And the success rate was more than 99%, and the adverse events were seen in 7% of these patients, primarily in the form of mild chest pain, and only 1 patient had a history of post-treatment pulmonary embolism. Out of these, 100 patients had follow-up for a mean of 529 days, and 93% of these patients had persistence of the gastric varices obliteration. Rebleed was seen in only 6 patients within 6 months and 3 patients after 6 months. Another useful concept that is evolving is the US guided liver biopsy, traditionally which is done by percutaneous route or the transjugular route or surgical. US guided liver biopsy holds an attractive alternative in these patients because it is less invasive, less painful, and patient recovers in a matter of few hours, or at the most 1 or 2 hours. And very importantly, we can have bilobar access for greater sampling, which becomes a huge issue, as studies have shown that discordance between 2 paired biopsies can be as high as 40%, especially in patients of NAFLD. The tissue sample length has been shown to be even more than 6 centimeters in few studies, and as much as more than 30 to 40 complete portal tracts can be seen. And this is a linear US scope at the GE junction, where 19-gauge FNA needle is being used, which is primed with saline with or without heparin, and just 1 pass is found to be enough. And even some studies have shown that even 1 pass and 1 actuation, that is just 1 to and fro movement, is found to be giving satisfactory result. Various studies have been published after that, showing the utility of US guided liver biopsy. And in general, it is recommended that we should be using 19-gauge FNB needle with wet suction technique, And studies have shown the successful histological diagnosis in nearly 94% of these patients and adverse events in 2.3%, mostly in the form of minor bleed. So US guided liver biopsy is ideally suitable for patients who are having an additional indication for liver biopsy or endoscopy, for example, for the varices screening or for any evaluation of the abdominal pain which is patient is having concomitantly, or the patient is having large body habitus where the percutaneous liver biopsy is found to be difficult. Also, if any concomitant liver lesion is seen, FNA of that needle can always be done apart from liver biopsy. However, it does require the need for anesthesia, absence of significant coagulopathy, and advanced endoscopy should be available. Another very interesting concept that is evolving is the US evaluation of portal pressure, because by doing linear US at the GE junction, we can quite easily see the hepatic vein or the IVC when we do anti-clockwise movement. And when we do clockwise movement, we come anteriorly and we can see the left portal vein or even the main portal vein in the liver parenchyma, which can be targeted quite easily. This is a device which has been recently FDA approved and available commercially, not in India as of now, from Cook Medical. It comes as an assembly of 25 gauge needle attached to a portable manometer. It is having advantage of routine compared to routine HVPG that it does not require any kind of IV contrast and there is no radiation exposure. And as we can see here, the pressure comes is quite easily with this, and we can see that we have punctured the hepatic vein here, the pressure is 6, and then subsequently we punctured the left portal vein, the pressure is 17, then we can quite easily calculate the portal pressure gradient in these patients. So this is a very recently published pilot study of 12 patients where US guided portal pressure measurement was compared with HVPG. Out of 12 patients, in one patient, US guided method could not be done because the IVC are very thinned out. And interestingly, 2 of these patients turned out to be patients of Budd-Chiari syndrome, in which HVPG could not be done. So US guided portal pressure measurement has got another advantage that in patients of pre-sinusoidal or post-sinusoidal hypertension, in these patients, HVPG either cannot be done or it is unreliable. Here, US guided portal pressure measurement can be done. And in this study, the pressure measured was quite similar in both the methods. And it had a very strong correlation with each other. Now coming to the last part of my presentation is the US elastography. As of now, very little data is there. Only one study I could find. And it is a prospective study of 32 patients where US guided elastography was compared with the fibroscan, and both of them were having quite significant correlation with each other. So to conclude, US has revolutionized the field of endohepatology, and it has evolved from just being a diagnostic modality to a therapeutic modality as well. And it has the potential to serve as a one-stop shop for the patients with portal hypertension, in the form that esophageal and gastric varices surveillance can be done. Now with the availability of the forward-looking echoendoscope, it should be done quite easily compared to the routine US scopes which are now available as of now. Gastric varices endotherapy, US holds a lot of potential. US guided liver biopsy or elastography can be done if required. And in future, we might be doing portal pressure measurement with the help of US scopes. And obviously, if concomitant SOL is seen in the liver, FNA of the liver SOL can also be done simultaneously.